Hello, I'm Judith Richards. I'm the creator of TRTP, or the Richards Trauma Process. Welcome to this webinar on client outcomes with TRTP. I will be joined by Dr. Petrina Barson, who's a medical professional, a doctor of medicine, a GP. Petrina is part of a very, very successful award-winning practice in Melbourne, Australia. She teaches at the medical department at the Melbourne University in Victoria, in Australia, and has headed our research team in partnering with the medical department at Melbourne University, and has recently, after many years, achieved ethics committee approval to begin our research on TRTP, proving the process. So without more ado, over to the webinar proper. Enjoy. Thank you.
Prior to training in TRTP, I was, using probably mindfulness-based therapies, acceptance and commitment therapy, and so forth, some cognitive behavior therapy, winging it a bit, but was becoming increasingly discontent, increasingly aware, I'd say belatedly aware, that the kinds of methods I was using were really teaching people how to manage symptoms, and I was getting frustrated because I was looking for a way to help people resolve the trauma that it was becoming increasingly obvious was at the back of the basis of their symptoms. And it seems, probably many therapists on the call will think that that's a strange thing to say, but I'd like to say that my medical training did not prepare me well to deal with psychological issues. We were taught really to do a sort of phenomenological approach, just a diagnosis and a labeling and medication, and then of course the therapies that I was learning were also teaching me about managing symptoms. But I could see that the people in front of me that it wasn't enough, that they were trying very hard to manage their symptoms. They were trying in many cases to do their best, to do their breathing exercise, their mindfulness exercises, but somehow something in them was too big to manage just with symptom management. So I kind of was looking around for some trainings that would help me to both safely and effectively manage the underlying causes, which I understood to be trauma.
So you were actively looking for something because you were so frustrated.
Yes, exactly.
Mm-hmm.
And I just didn't think I had found anything that was both safe and effective. I'd, done a little bit of training in age regression therapy, and I wasn't too enamored with that. I saw it as a little bit dangerous.
Yes.
And
I didn't like it the first time. Please don't take me back there again.
Yes, exactly. And so what happened was, one of my patients who had had depression for yonks, largely because of having had a violent alcoholic father, I sent her off to a local clinical psychologist, and she came back a month later fixed. What I mean by fixed is she said, "Oh, Petrina, I'm not depressed anymore." What happened? I said, and she actually hadn't gone to see the clinical psychologist that I had sent her to. She'd gone to see a different clinical psychologist, and that clinical psychologist had taken her through this weird thing called the Richards Trauma Process, and she described it as weird. And I said, "Why? What did they do to you?" And she said, "Oh, I don't know. It was really weird and it was intense, but gee, it was good, and I'm not depressed anymore." She couldn't really give me an account of it. Yeah. So therefore I rang the clinical psychologist. I was almost a bit put out. How can you fix someone in a month? And so I got on the phone and spoke to this clinical psychologist, who was a very impressive and articulate woman. And she gave me a very good account of what she'd done in this therapy. And I guess I it resonated. It really resonated. It gave me a sense, right, okay, this is the kind of thing I've been looking for a long time. So I sent about 8 of my patients off for it. And most of them came back with the similar kinds of results. So I then went and did the training myself.
What year was that now?
2018.
Right. So you've been doing it for about 5 years now.
Mm-hmm. Mm-hmm.
That is terrific. So you have actually kept extraordinary documentation of your results. You were the first to do so, which set us off to do an audit using your famous spreadsheet. And we did an audit over 715 clients, and we got an outside statistician, Dr. Jeff Lyons, a clinical psychologist in Sydney at one of the universities there, to do the stats and to write the paper. And he found that 89% of people with on the DASS, so we did DASS, a depression, anxiety, stress score. For those who don't know, it's a subjective stress score to check where someone's at in terms of depression, anxiety, and stress. And we do one in session 1, session 3, and then generally a month down the track. And some do them 6 months after that. But we did session 1, session 3, and a month down the track. And the results were 89% of those with extremely severe anxiety went to normal, because with the DASS it goes normal, moderate, severe, extremely severe. So 89% with extremely severe came down to normal, 92% of extremely severe depression came to normal, and 96% of extremely severe stress went to normal. And you have the original spreadsheet with the DASS set out and what your results were, including those who didn't complete the sessions, including those who had other things going on at the time. It's really comprehensive. Are you able to share that with us, Petrina?
I'll be very happy to. Just give me a moment.
Sure. Certainly. And we'll have about 15 minutes at the end so that people can ask their questions. So hold on to your question.
So let me explain. So what you're seeing on the screen are my pre, post, and follow-up data. So color-coded, so that the redder it is, the more extreme it is. These are DASS scores that are not doubled. If you're used to dealing with the DASS as opposed to the DASS 21, these are I haven't doubled these scores, so they're sort of raw scores. And if it's red, it's extremely severe. If it's orange, it's severe. Yellow is moderate. Blue is mild, and green is normal. So these are my early clients. The first 3 columns are pre. The next 3 columns are at the beginning of the 3rd session, and the adjacent columns to the right are if I've got follow-up data. I haven't got follow-up data on everybody. Mm-hmm. So I guess just sort of scanning down these pages, these screens, you'll see that it's reasonably graphic.
Yeah.
That there are big changes, and of course not for everybody, you know.
Yeah.
I would never say that it works for everybody.
No.
I don't know. I've never encountered a therapy that does this, you know, that takes people who are extremely severe.
Okay. Do you want to pick one out there, Petrina?
Sure. Because I've hidden the names, I don't need access to the names. But I guess just to talk you through, let's say number 54.
Yes.
So
depression,
extremely severe,
18.
anxiety and stress severe.
Mm-hmm.
So at the beginning of the 3rd session, normal, and normal. And as often happens, I find that
Yes.
follow-up, which I do at 2 to 3 months, some people do it at 1 month, I do it at 2 to 3. At 2 to 3 months, they're often even better.
The scores go down.
Often they go down.
So, yeah. So,
and I believe that's because people have had a chance to live into their recovery, to experience the new normal for them.
yeah. So you've gone from 18 out of 21 for depression, which is extremely severe, severe anxiety, severe stress, down to normal, 227, and 4 to 6 weeks later, 112. And we see that a lot, don't we, Petrina?
We do. I think the other thing that I noticed today when I was looking at this spreadsheet, the other thing that I notice is the evolution over time. So if you go in my practice,
yeah,
and it only occurred to me that as you go down this spreadsheet, there's more green.
yes,
because I've gotten better at it. And again, not universally, that's a relapse.
yeah, that's a relapse.
Relapse at 2 to 3 months. But on the whole, I'm getting more robust results because I'm getting better at it, and because I'm participating in the community of support around TRTP that gives very the most valuable education that I think I've ever had in mental health. And on a weekly basis, I'm participating in that.
Right. So you're saying the TRTP practitioner community, with our ongoing professional development, etc.
Yes.
That you haven't had such in-depth, continuous education.
I give up an hour of consulting a week only on TRTP. And I mean, that might not sound like much to some, but it's a lot to me. I don't give up an hour a week for any specific aspect of my work. I'm a GP. I have to know a bit about everything. I have to know a bit about heart failure and ingrown toenails and blood pressure, and
yes.
I have to know a bit about everything. But this education that every Friday morning I'm on a 1 hour call, or I have been. I give up that hour of consulting because it's so valuable, the education that we get.
That's great. Thank you, Petrina. Do you want to stop sharing screen, or is there something more you wanted to say about your wonderful, colourful spreadsheet?
Well, not specifically about the spreadsheet, but just that I'm heading up it. So that's my own data. The data that we collected in the audit was very compelling, but it was not publishable because it didn't go through an ethics committee.
Yes.
And so I'm therefore heading up a research project that has gone through an ethics committee at Melbourne University to do a pilot.
Yeah. So doing a research project about TRTP, and you've spent a lot of years working on that, and finally you've achieved ethics committee approval. So tell us a little bit about that project, Petrina.
Yeah, so it's just a pilot study. There's no control. It's just we'll be collecting 20 clients' data, pre, post, and follow-up, DAS scores, PCL5 scores, which is a survey looking at symptoms of PTSD, but again PCL5 at pre and follow-up. And it will just be we'll be noticing whether there's a change or not and what degree it reaches. And so that I think that will be finished this year. We'll have the data, I'm sure, by the end of this year, and then to use that as the basis to get a team together to do a more robust study with a control group and so forth.
All right.
But these are sort of the steps you have to go through to climb the evidence ladder.
It takes a long time.
A long time.
A long, long time. And people say, well, why aren't you evidence-based? Well, I started teaching this in July 2014.
Yeah.
You came on in 2018, and you've taken this and run with it and run and run and run. And it takes a long time to get through ethics committees, et cetera, and then they'll be gaining funding, et cetera. And then the big research project will take some years. And we all love you for doing it, Petrina. Just saying.
Thank you.
Yes. And so you came to TRTP looking
Mm-hmm.
for something more effective that wasn't just managing symptoms
Mm-hmm.
and not just requiring huge discipline from the client to be mindful and do the breathing and do all of that. How did you find the training? Tell us about your experience of that.
I remember in the lead up to the training, one of the sort of questions I think I had to answer, sort of, I suppose it was a question that was meant to make us reflect, and that was, how teachable are you? And I reflected on that, and it made me think, look, I'm ready to learn. I don't feel like what I'm doing is working. I'm ready to set aside some preconceptions and learn. And that isn't to say that, during the training I didn't feel a little rattled. I did actually,
You did.
I did, because it's like, whoa, where's my ground? This is all very different from what I've learned before. But it still had that intuitive appeal, and it still had, I had the evidence, I guess, from my own patients that I'd already sent off for it, that they had got something from it. So it was worth kind of setting aside my comfort zone in a way in order to learn something different.
Because the model of TRTP is quite different from the normal accepted status quo model of how trauma works, how anxiety works, how depression works.
Mm-hmm.
It is quite different.
It absolutely is.
So that takes a bit of a leap for some people.
Yes.
But the proof's in the pudding, really. If
And
the model doesn't work, well, TRTP wouldn't work. And the model is different, TRTP is different, and the outcomes we get are consequently different. We must be doing something different. If we're not just managing symptoms, we're resolving the symptoms and the main issues.
But also, we're not just going for understanding. I think that a lot of more psychoanalytic therapies, they go for understanding. I'd like to understand why I am this way, and that perhaps that might help me manage it. But it's not clear that it's never been clear to me that that's always the case. That just because you understand where your difficulties come from in psychodynamic terms, that means you'll necessarily be able to better manage them. And certainly my experience clinically was that, that people came back to me and said, well, it was, how's the therapy been? Because I don't counsel every person. I do so much mental health that I used to refer a lot of people off. So, but they'd come back to me, how's it going? Oh, it's good. And what are you getting out of it? Well, I think I'm coming to an understanding of why I am this way, or I'm learning some breathing techniques. I always came back with breathing techniques to manage their symptoms. And what I saw was people, yes, getting support, yes, feeling maybe a bit held and contained, but not necessarily coming back with profound differences in their scores or how they were being in their life.
Such a shame. Yeah. And so after the training doesn't just finish. We don't just say, like you go to a lot of trainings and they go, bye.
Yeah, no.
But we don't do that. At the end of the training, the real learning begins. Working with clients and being supported in that by the TRTP practitioner community. So you're talking about the once a week you give up an hour, which is huge in a GP practice where you earn by the increment. So you're giving up income, you're giving up that time to do that hour of professional development each week, as well as the other training that is available and the other support that's absolutely there, supervision, etc. And it's evolved over time.
Yeah.
It's become, the reports that people say has become richer and more spot on, more what's required at the coal face.
Yeah, and it's very much a communal thing. People in the community contribute to the development of the therapy. Judith's the main inspiration and founder, and she's the genius, really. But we all kind of modify and contribute ideas and refinements, I guess, to the therapy.
Yeah, it's growing. It's alive. It's
dynamic.
It's very much a communal effort.
But just having that feeling that I've got a patient in front of me who's distressed, often deeply distressed, and being able to say to them with my hand on my heart, I know what to do to step you to the other side of this. That is just profound. And it's so empowering as a therapist. So let me tell you one couple of stories. Would that be all right?
Tell us a story. We love stories, Petrina. Tell us a story.
So one of the most rewarding things is when I do this therapy with my very long-term patients.
Oh, these poor people who've been struggling for so long.
Yeah, that's right. They have, and they've been struggling for a reason. I think of one patient who, she'd had more sexual assaults than I've had, I don't know, trips to Luna Park, I suppose.
Yeah.
And, she was suffering from chronic pain that started during one of her sexual assaults.
Yeah.
She had a termination because of one of the sexual assaults. She had a really shitty time, basically.
Yeah, I think that's a technical term. Thank you.
That's right. And she was profoundly impaired. She was in my office all the time, weeping, crying, physical symptoms, pain, mental distress, kind of collapsing. The way I sometimes think of it is like people have lost their stuffing.
Yeah.
And she didn't have her stuffing. She was collapsing. She was dissolving in front of me all the time. And so I, after getting to know her, after getting trust and working with her on her physical symptoms and so forth, I was able to do TRTP with her. And she's like a different person. I hardly see her. She was on the disability pension. She was on the NDIS. She's now working full time in a job that enables her to contribute very substantially to the lives of children.
How wonderful.
Yeah. And, I don't see her when we have a phone. She's living somewhere else now. When we have a brief phone call, we have a bit of a laugh and a chat. And it's just, it's very addictive, I should say. This kind of work it's very Moorish. And maybe sometimes too Moorish, because I have to watch it that I don't just sort of offer it to absolutely everybody, try and fix the world. That it is important probably to select people who are appropriate, and that's not everybody.
Yeah. So people have to be really ready and able to embrace change.
Yeah.
And there are a few other things that we won't go into right now, but they have to be a suitable candidate for TRTP.
That's right. So my receptionists even comment now that after the patient has done TRTP with me, we don't see so much of them. They're not ringing up as often, needing kind of emergency help and emergency holding. What's another story? Well, actually, most recently, I've done TRTP with a patient who has a refugee background.
Yeah, because you work a lot in refugee support.
Yeah,
extraordinary work that you do there. Yeah. So tell us about this person with a refugee background.
So I want to be careful just about preserving anonymity here. So I'll be very small. But just let's say, completely fucked by the Australian government. We'll just say that.
We'll just say that because that's what it is. It is what it is. These poor people.
Exactly. Severe anxiety symptoms that were really impairing his life. Like he could hardly go out the door. And when he left his second session, because that's where the rubber hits the road really, in the second session, you do the big work there.
Yeah.
When he left his second session, he said to me, I'm going to go and get a pizza. and I'm going to eat it, and I'm going to step on the cracks, and I'm going to, and he just reeled off all these things he was going to do that he hadn't been able to do for months, years even.
Yeah.
And that's gold.
That is gold. And what Petrina's talking about is it's generally a 3-step process, often 3 sessions. And in the second session, that middle session, is where the rubber hits the road, where we do the big work and we remove the distress from the past. And what happens then is people are no longer triggered. The symptoms, whether of anxiety, depression, PTSD, DID, whatever it is, simply disappear because we've dealt with the reason, because those symptoms, anxiety, depression, etc., PTSD, are simply symptoms of events that have happened in the past that have never been stored properly in long-term memory, and instead they're stored in the unconscious and in the body, and we just turn that off. And the whole system comes back to calm, like a factory reboot of a mobile phone. The physiology, brain function, because brain function changes with big T trauma. It changes the brain changes in function and in structure in very predictable ways. So the trauma brain is very different from the normal brain. And we have EEGs. We're doing more EEGs going forward, showing the trauma brain returning to normal function. And anxiety, depression, etc., are not caused necessarily by big T trauma. It can be small, everyday traumas. Petrina, we see that so often as well, don't we?
Yeah.
Yeah.
I think it's important to say that when this client, for example, leapt out of my room saying, I'm going to go and get a pizza.
Get pizza.
Yeah. He said, I'm going to go and get a pizza because I like pizza, meaning I haven't been able to do anything I like for a long time. But it wasn't, I'm going to go and make myself do that. It wasn't, this is an exercise in exposure that I'm going to go and make myself do.
I have to do it because it will eventually make me feel better.
Yeah.
If I just make myself do things that terrify me.
Exactly. It wasn't exposure therapy he was deciding on. It was just, oh, now I can, and that's amazing.
There's a big difference between getting people to a point where they can talk about what happened to them without being triggered. There's a big difference between that, which can have the outcome of people just numbing, and having someone come alive. And come really alive, and not just being, not just existing, not just surviving, not just trying hard to get through the day, but come alive. Go and get a pizza. Go and do stuff. Get to a place of actually thriving, which we see again and again and again, but so quickly, Petrina.
Yes, as I say, it's very, very Moorish sort of work.
It is. It's addictive because we see people change.
Like immediate gratification, that's why.
Yeah. Dopamine hit. Yes.
Yeah.
And so our practitioners report they go home rather than exhausted after all the talk therapy, because TRTP is not a talk therapy. It doesn't re-traumatize the client, because we don't do we don't do talking. We don't get the client to explain and to understand what happened to them. We just go in and resolve it and turn off the distress of the past in the unconscious and the body, because we think if we can use that conscious, most therapies use the conscious mind to control the unconscious, which is where trauma is stored in the unconscious and the body. The conscious mind has been proven to run 5% of the time. And to use that 5% to control what's going on in the 95% just doesn't add up logically, does it? And people try to manage their symptoms and do the right thing. It's like holding balloons underwater. There comes a crisis of exhaustion and the balloons pop up. And this just gently deflates those balloons. So triggering stops, anxiety stops, PTSD, depression, etc. There are a few questions starting to come in. Shall we go there, or do you have something more that you'd like to add, Petrina?
Oh, could talk for hours, but I'm very happy to ask.
Well, maybe these questions will trigger more conversation.
Sure.
Philippa, I've been meaning to give you a call. Philippa in Tasmania. Does being on antidepressants reduce the effectiveness of TRTP? Does it numb people and then the process doesn't work as well?
I don't think so. A lot of my patients are on antidepressants. And, you know, we always say don't change your medication while or soon after you're doing TRTP. What I think happens is that for many people, and, you know, got to be careful about this, but for many people, after TRTP, we can gradually talk about reducing, which is what I do if they remain well, which they usually do.
Yeah.
So it's not. I've never had the experience that being on antidepressants is a problem. What I don't like is when some psychiatrists, at the same time as I'm starting TRTP, starts them on antidepressants at the same time. So yeah. So I generally try and enforce that, you know, please don't change anything while we're doing the therapy.
Don't change meds during the therapy. Don't start new meds during the therapy. And when I was in practice, if I didn't see people on antidepressants, anti-anxiety, I wouldn't have any clients, because nearly every one of my clients was on those meds. Hello, Philippa. Techniques like hypnosis and NLP work on the unconscious mind. How is TRTP different? Well, the first thing to go to, Philippa, is our outcomes. So, for example, David Clough, one of our practitioners, had a man with over 100 personalities with DID. And by the end of the second session, the spokesperson for the personality said to the bloke, let's call him Dave, hey, Dave, it's over and we're safe now. And it's over and you're safe now. So you don't need to hear from us anymore. And that's nearly 3 years that he hasn't heard from them again. So it's the outcomes that are so extraordinary and long-lasting. Petrina, have you found that?
Yeah, on the whole, I won't say completely.
No, it's not completely, because people go back into toxic ponds and yeah.
Exactly. So I've done TRTP more than once with a few clients. Often the second time it's more effective because they've sort of had a practice run. But, you know, so no, not always, but very often long lasting. So, you know, I have one of my clients who's a particularly fertile source of referral. She just keeps sending people to me. She was someone, again, from a refugee background, but as a child she came here, you know, and she'd had every kind of trauma you can just about imagine, including a refugee journey and domestic violence and all the rest. And, you know, she sends me every couple of months. She sends me a new referral because she's still fine, and she definitely was not fine when we began.
No, and people see it's it's so obvious that a lot of people see someone going back in their family, their community, their workplace, and they go, I want what she's having. And so they come asking for TRTP. I used to specialize at one stage in violent, angry men brought against their will. So extreme domestic violence, like one guy, Jason, you've heard this story so many times, Petrina, but Jason that morning had smashed every window in his ex-wife's house, every panel in her car, and was pulled off strangling her by the men in his family. And he was a very violent man. And we did TRTP. At the end of our first session, he was safe and everyone was safe. And that was 11 years ago, and still in touch. Lots of my violent, angry men are still in touch every few months. And Jason's never had a rage outburst since. He's had the gradual build of irritation, frustration, resentment, but not that rage, lit match at petrol, violent trauma rage. Not because he's learnt to control it, not because he's learnt the breathing techniques and the mindfulness. No, because hurt people hurt people. You take away their hurt, they stop hurting people. He's not angry anymore. He doesn't have that response anymore, not because he's trying to control it, it's just not there. And that's what you're talking about, Petrina, that lovely refugee skipping out of your rooms going, I'm going to go and get a pizza. People step into life and it's exciting and it's addictive because you see it again and again and again and again. What does TRTP stand for, Jean? It's the Richards Trauma Process. I'm Judith Richards. I created TRTP out of my own journey through extreme violent trauma. And so that's where TRTP comes from, my own lived experience. And I figured out how to fix it. And I've now taught about 700 mental health and health professionals how to take their own clients by the hand to the other side of their pain. I'm just reading some of the questions here.
The one from D is very important.
Yeah, okay. When D says, is that's one Petrina is talking about a client who had previously been sexually abused many times. I'm wondering how TRTP works as they talk about perpetrators being able to spot their victims. That is, how do we change that victim perspective stance? Oh, I love this, D. To give them understanding as to how we contribute to being a victim. How do we also work with empowering our clients? Thank you, Dee. Do you want to talk about that?
Well, we don't give them understanding. That's not how it works.
We don't.
We
don't give them. We just turn off the pain. Over to you, Petrina. I'll stop.
I'm sorry.
No, I get a bit carried away, a bit excited.
I always say to my patients that there are two things that turn a difficult event into a trauma. And that is, the first is feeling disempowered, and the second is feeling alone with that event. And so the way TRTP works is it works on, especially in session 2, we work on both of those aspects of a trauma. And so in the process of re-empowering the person in relation to trauma, they move from being a victim and feeling like a victim, having all the responses of a victim with the rage and the sense of being invaded and stepped on and so forth that a victim has. They move from that spot to feeling empowered. And when they feel empowered, they really do radiate a different energy. It's like the energy of self, the energy of, I've got this thing called life. And you're not going to fuck with me anymore. And it's not that they're angry anymore.
They're not angry.
The anger is actually resolved in the process.
Yes.
It's kind of a quiet energy of, I'm no longer a victim.
I matter.
Yeah.
I'm enough. And I know who I am.
So they get this thing back. Sorry, Judith.
Yeah, carry on, Petrina.
Well, it's like they get their stuffing back, they're, instead of sort of being kind of collapsible all the time,
yes.
Which is a victim place to be. They're standing in their own strength, knowing who they are, knowing what they deserve, which is that they deserve to be treated with respect, with kindness, with love, and they're not going to take any shit anymore.
And the fear disappears, because fear to a perpetrator is like blood in the water to a shark. I can talk to this very well. I used to, by the time I was about 18, I would introduce myself. Hi, I'm Judith. I attract violent lunatics. What can I say? It's a gift. And I worked my way up through, pedophile priests and pedophile nuns, through stalkers to violent relationships, to more stalkers, to rapists, to whatever, till I found myself with a homicidal psychopath who was into torture. I was a walking target for perpetrators from when I was very, very tiny. And now I have a loon-free zone for kilometers around me. I don't have fear. And I know who I am. I've seen it in hundreds and hundreds and hundreds and hundreds of my own clients. Can you see anything there? Any questions there, Petrina?
So Philippa
again. I have a client who have worked through trauma with the EMDR, which cleared the traumatic event, so it wasn't traumatizing her all the time. She noticed a significant change around that, but she still constantly has fibromyalgia flare-ups. Yes, I could get excited about this, but and other weird health issues and really negative beliefs about herself. She still can't say I'm enough. She still feel like a failure. Does TRTP help with this as well? And not just clearing trauma? Abso-fucking-lutely, Philippa. Sorry, jumping in there, Petrina. But fibromyalgia, Bessel van der Kolk in his book, The Body Keeps the Score, draws a very clear parallel, a connection between fibromyalgia, chronic fatigue, and lupus and trauma. And yes, TRTP, EMDR work on specific traumatic events. TRTP reboots the whole physiology as well as brain function. So those issues of fibromyalgia, etc., those other health issues. I've had so many people with fibromyalgia where it just, at the end of the second session, it just disappears. Same with lupus, same with chronic fatigue. It's just what happens. Petrina, do you want to talk to that at all?
So I can't speak about lupus particularly, but my experience with chronic fatigue and fibromyalgia is that it makes a significant shift, and that may be, for me, in my experience, that may be a gradual thing. So there's a very significant shift with TRTP, and then they live into it, and the fibromyalgia and the chronic fatigue improves over time. But that may not be, I don't know, is that your experience, Judith, or are you?
No.
No.
We can go to the YouTube channel and see some videos of people with fibromyalgia, etc., where it just disappears and they're running around with pain-free. But that's my experience. And other health problems, some of those as well. And going on to some other questions here.
Anthea says she went through TRTP as a client after having been through developmental trauma, sexual abuse, etc., and poor adult relationships. TRTP was my last stop. After first session, the weight of the world lifted.
Yeah, good on you, Anthea. Go you, darling.
Nothing else helped over 30 years of seeing a psychologist.
Yeah. So it is, you know, a lot of people say, well, it's too good to be true. So yeah, it sort of is. But the bar is so low in mental health.
And it also says, I have fibromyalgia, but mine's still rampant.
Right. I would say there's more to be done. Who said that? Oh, right, Anthea. Mine's still rampant. Okay, Anthea. Well, you're not done yet, darling. Sorry. In my experience, Andrea, do you recommend TRTP for people with low depression, anxiety scores, perhaps moderate stress scores as a means of personal growth, overcoming inaccurate beliefs? Petrina, would you like to say something about that?
Well, every potential TRTP practitioner has to do TRTP as part of before they begin the training. And, you know, hopefully most of us aren't very impaired beforehand.
Yeah.
So yeah, it still can be a life-changing experience.
Well, I did sorry.
Well, it was for me.
Yeah.
Strangely, particularly session 1 was for me.
Right.
But most people, they see the real changes after session 2. For me, it was after session 1. I walked out of that feeling ennobled.
That's a lovely word, Petrina.
What's the word that your young client used? Embiggened?
Embiggened.
I walked out of session 1 feeling embiggened.
Yes, that was a little girl. I said, how are you, darling? I just feel so embiggened. It was just, that's a wonderful word. It's a real word. You can look it up in the word book. Oh, the dictionary. Yes. Yeah. It's just great. I did a webinar last week with Sally Wilson. Sally was a very successful opera singer and works now with very high level achievers, top athletes, business people, entrepreneurs, performance artists, And she thought she had her act together. She'd been very successful. She'd had a successful career, et cetera, et cetera. She thought, well, I don't have any trauma, but I'm doing the training, so I'll go through it. And she says her whole being changed. She didn't have her perfectionism anymore, her absolutely unattainable personal standards that she beat herself up with and was guilty about every day. She didn't have imposter syndrome. Changed her life, and she became very happy and relaxed and enjoyed her singing, and just became so much more creative. So yeah, people don't have to have great big T trauma. It can be just little stuff, but it takes that all away, removes our baggage so that we can soar, so that we can truly live and not just live down here. So for creatives and for people who have their act together and they do TRTP, it still takes them to the next level.
There's a question there from Jen. How effective is TRTP with clients with personality disorders in addition to Axis 1 diagnoses?
Just trying to find, is that a fair way back?
Fair way up, yeah.
Okay, I'm just trying to find that. Bear with us, Jen. Would you read it out again, please, Petrina?
How effective is TRTP with clients with personality disorders in addition to Axis 1 diagnoses? Yeah. So personality disorders.
Yeah, personality disorders. Borderline personality disorder, people suffering from that. It's a spectrum from mild to extreme. TRTP can be effective with more extreme. After it takes a long time to do other work with someone who's suffering from the challenges of extreme borderline before you'd even go there with that. TRTP doesn't fix borderline personality disorder by itself, just saying that. In terms of, do you want to say anything more about that, Petrina?
I did TRTP with someone with a narcissistic personality disorder. It was
Good heavens.
It was a complete flop.
Yes, because there's nothing wrong with them.
No. He just talked about what was wrong with his wife. So
well, exactly. It's not him. If you just fix my wife, everything would be fine because she's the one with the issues.
Yes, exactly.
Yes. So personality disorders is something else altogether. Having said that, we've had some extraordinary results with DID, dissociative identity disorder, and some of those, and just dissociative disorders. So just going back through, there was some person here talked about the training. Someone sent me a message earlier. The training is a 10-week program now. It's not just information and knowledge. In the second half of it, you work with clients as well. And as Petrina said, at the end of the training, it's not the end. You go into the TRTP practitioner community where there's ongoing professional development. The training is comprehensive. Somebody asked earlier up, can we explain the 3 sessions, please? In a word, no. Sorry, there's a reason why. I'm just trying to find that who it was. I'm sorry, I can't remember who asked that question. Can we explain the 3 sessions? I won't spend time looking for it, but to the lovely person who asked that, the reason I say no is in the beginning of TRTP, I used to set out exactly what we did with the provisos, saying to the audience, please don't use this at home. Please don't use this until you've been trained, because if you don't know what you're doing, you can re-traumatize somebody. So don't use it. So what did some of the people attending my lectures do? They went and used it with some horrendous consequences. So I vowed at that time I'd never put anybody else at risk, and I vowed I would never actually go through the points of what TRTP does, because a little bit of information can be a dangerous thing. So I hope you understand my motivation for not giving you the exacts of what TRTP does, besides the fact that we don't have time, we're running out of time. Anthea says, what date does the training start in July? That's a really good question. I don't know.
And someone also wants to know if you ever do face-to-face training, not just online.
No, we don't, because about half of our practitioners now in our classes are coming from overseas. And so it'd be very expensive for them to come all the way here. So we're finding it really effective online for the training. I'll just look, if you look on the website, and I'll just share the website with you in a moment, you can find out where the training is. So I'm just going to share screen myself here and go to the website. The website is trtptherapy.com, trtptherapy.com. I'm looking for a practitioner. I'm looking for TRTP training. So go to that one. And then you can come up here to the menu and go to training events, and the next training begins July 17. There we are. July 17, and the early bird discount, which is massive, ridiculously massive, finishes in about a week or so. So if you would like to inquire about the training, let me just go back to the website here, and I'll show you what to do. It's really simple to inquire about the training. You go to here, I'm looking for TRTP training. Click on that, and the next page, book a 30-minute training Q&A. On that page, you can hear me talking about TRTP, explaining it in much more detail because we didn't have time today. But if you click on book a 30-minute training Q&A, you come to a calendar, click on a day, and then you can click on a time that suits you. And gorgeous Lisa will give you a call and answer all your questions and see if we're a match, see if you're a match for us, we're a match for you. It's just an inquiry call. Lisa's great value. Lisa has put in July 17th is the start date. When's the, Lisa, who's watching, when does the early bird stop, Lisa? Thank you. 17th of June, the early bird goes for another couple of weeks then. So there we are. It is now the hour. Apologies for the buzzing at the beginning. I'm glad that we got that sorted. Philippa, what's the average price practitioners charge patients to do the TRTP process? Psychologists charge at normal psychologist fees. Clinical psychologists charge at normal clinical psychologist fees. You know, it depends on what your practice is, what you would charge. So generally, you know, you do your first clients and you get your money back basically, and then you're off and running so that you can really be effective in taking your clients by the hand to the other side of their pain. If you're interested, yep, clinical social worker charge, whatever. Thank you. If you're interested, could you just type in interested and we can send you some information and get in touch with you. If you're interested, if this sings to you, if this resonates for you within your whole being, because it's not for everybody. And the other thing is we don't accept everyone who applies for enrollment, but come and we'll talk with you and see if we're a match. So if you're interested, type it in and we'll send you some information. We'll be in touch. Lisa will give you a call. And at the end of this, you'll receive in the next few hours or in the morning an email where with that link on, where if you want to make an appointment, come and talk to us. We have to use processes that are effective rather than just deal with managing symptoms. Thank you so much, Petrina, Dr. Petrina Barson. Thank you for being here. I always love hanging out with you, Petrina. Thanks so much. And thank you, everybody who's invested your time, your energy this evening or wherever you are in the world, whatever time of day. Lots of love. Thanks very much. Thanks for coming.